much ado, I'd start this program for today with the case presentation by Dr. Jacob Thomas. You see this biodata slide, you don't know where to start, where to end. It's it's so much. He's done his MD, DD, MNMS, PhD, FAD. Some of these degrees, I don't know what they are. He's got FRCPs from 4 places and FRC PCH. And he's presently the emeritus professor Tamil Nadu, and IMA professor dermatology from New Delhi. He was a former national president of the Indian Association of Dermatologists, Venereologists, and Nephrologists, 1998. Professor head of dermatology at Tanjavur Medical College, Tanjavur, and Sri Balaji Medical College, Chennai. 40 years of PG teaching and training. That's the experience that you're going to learn from today. He's the national president of, as we also already mentioned, national president of the Indian Society of Teledermatology, and international president 2012 and 2014 International Society of Teledermatology. His major achievements have been the KC Khandari Foundation Award, Lifetime Achievement Award for Teaching and Practice of Dermatology, the Mother Teresa International Award. He's had the International League of Dermatology Societies Award of Appreciation, IMA Best Doctor Award, and the IBAVL Teacher par Excellence Award. Published so many papers, and his contribution to dermatology is immense. I invite you, Dr. Jacob Thomas. Thank you for being with us to talk on your introduction to this topic and the cases that you would like to discuss.
Thank you very much, Dr. Jason. First of all, good evening to everybody, particularly the Kerala branch, IAP branch, and that was the Cochin branch for being so kind for inviting me. So I'm very grateful to all the officials for inviting me. Can I have the next slide? Can I have the next slide, please? I will start with that. And then you go, yes. Now, I just thought I will describe this slide. The picture you can see on the left shoulder, an hypopigmented patch. And you can also see the sutures which are remaining there after a biopsy was done. But what is very interesting in it is you have a good look at the edges of the lesion. You find that in the anterior aspect, there are small little projections of the hypopigmented patch. Now this we tend to call as satellite patches. But if they are separated from the main patch, that would be a better name for it. But still here, we call it spurring of lesions, where the hypopigmentation is spurring, which is an indication that this child's immunity is not all that good and it's not getting confined to one particular portion of the body. It's tending to spread. Whereas, if you go to the next slide, please. Here you will see, now this is very, very interesting. Two different children, the one on your left, again you see a huge patch, a huge patch. Now I generally start off my talks on leprosy with the definition, and it's best to define leprosy as a chronic, sometimes infectious disease caused by Mycobacterium leprae, primarily and predominantly affecting the peripheral nerves, and secondarily affecting the skin and so many other organs, starting from the eyes to the testes. Now, it has to be remembered that the eye becomes a very, very important organ where leprosy is concerned, but I still have to tell the impact on the peripheral nerves. Now, in a patch like this way over the face, on the left cheek of the face of this child, now, this is one of those lesions which one has to be very, very careful about because of its proximity to the facial nerve. And one has to definitely palpate the facial nerve, and not only the facial nerve, but also its twigs and branches. And the best thing is to run your thumb around the patch, firmly around the patch, to make sure that there are no cutaneous twigs that get involved. That's very important because once the cutaneous twigs are involved, we'll be able to palpate it when you run your thumb around the patch. But here you find there is only hypopigmentation, and right in the center of the lesion, the skin appears to be normal. You compare it with the normal skin. the normal skin and the center of the skin, you'll find that they're almost same. So this is a ring-like lesion almost, although we wouldn't want to call it annular, but it's a ring-like lesion. And now this is an indication, as against what we saw in the previous child, that some amount of immunity is still there. And therefore the child's skin is normal in certain areas of the patches, in between the patches. Now we'll go to the picture on the right. Now this is important because as I'm sure Dr. Narasimha will accept that important point that I'm going to bring out in this. First of all, as I told you earlier, leprosy is caused by Mycobacterium leprae. Now, Mycobacterium leprae, we should all remember, is an intracellular obligatory pleomorphic bacillus, acid-fast as well as gram-negative. And an important aspect of Mycobacterium leprae is its coat, its cellular coat, the phenolic glycolipids that we call. Now, this is important. Why I'm telling you about this phenolic glycolipid is when we come to the treatment, which Professor Najeeba Riaz will be dealing with, she'll be telling us some of the drugs that are used and particularly the newer drugs that are useful. Now, with this phenolic glycolipid protein, which is present in the coat, it stands to reason that there are certain antibiotics that can never help in this, particularly when we are talking about common antibiotics. We always like to say, particularly in pediatric practice, give something common. So none of the penicillins or the penicillin analogs will not penetrate the bacillus, simply because penicillin does not act on lipopolysaccharides as well as the protein layer of the phenolic glycolipids. That's why there are so many other antibiotics that can help. Your drugs like the macrolides, azithromycin can help. Your fluoroquinolones can help, but not your penicillin at all. If that helped, it would have been very, very good, but that's not the case. So anyway, that apart, what I would want to appreciate in this is the redness that you see around the periphery of the lesion. The redness, very well marked out there, which shows that there is some amount of inflammation. That's what we call as erythema. We want to describe this patch, we call it as an hypopigmented patch with a halo of an erythematous lesion. Now, an erythematous lesion, we have to distinguish erythema from sometimes reddish lesions like a purpura. The easiest thing is to do what is known as diascopy, or even with your finger, with the pulp of your finger or the pulp of your thumb, you press on the redness. If the redness disappears, it is erythema. If it does not disappear, it means blood is stagnating there in the form of a purpura, or it could be a hemangioma, something like that. But we won't go too far away from what we're trying to do. But look very close to the patch on the left side of the patch. You'll find that the skin is all wrinkled and you find striae there. Now, here is an indication. I must confess very humbly that this child has been wrongly treated. As what is done usually, once you see redness, the first thing that you want to do is apply a steroid to bring down the redness. And that's why some of the redness in most peripheral part has disappeared. A steroid has been applied and been applied for a pretty long period. That is bad. And Narasimha Rao, with other of the presidents which we had earlier in the recent past, has always been talking about the misuse of topical steroids. And this is one clear example of where topical steroid has been misused. Now, when we come to childhood, when we come to childhood leprosy, if at all we are using a topical steroid for any indicated condition, one has to remember that the absorption in children of a topical steroid as compared to in an adult is almost 3 times, because the body surface area to body weight proportion is 3 times that compared to an adult. So whenever we want to use a topical steroid, if at all we're using for an indication, definite indication, we have to use 1/3 the strength and 1/3 the quantity. So 1/3 the strength and 1/3 the quantity. So in childhood leprosy, the use for a topical steroid is not necessary at all, And when we talk about childhood leprosy, it's important for now, way back around the year 2000, a common statement used to be made. One third of the leprosy population are Indians. One third of the leprosy population in the entire globe are Indians, and one third of the Indian patients are children. Now, of course, things are coming down. Around 8% or so are thought to be children. I think those days is 30%. I say that's a staggering big number. And therefore, when I was a postgraduate student way back in 79, 80s, we were taught that we must learn to treat these patients. First of all, diagnose correctly, then treat them and prevent the complications which are so common. And the complications, as I told you earlier, it is a disease predominantly and primarily of the peripheral nerves. So one has to make sure that the peripheral nerves are normal. And when we talk about normalcy, we talk in terms of not only thickened nerves, but also tender nerves and also cord-like nerves. Not thickened alone, cord-like, it should be hard. And that's why we started coming out with criteria to make a diagnosis. Now, when I teach my residents, I teach as 3 relative criteria and 1 absolute criteria. Now, the 3 relative criteria are, number 1, hypopigmented patch. Number 2, sensory impairment. Number 3, a nerve thickening. When you find any one of the 3, you must suspect Hansen. One must suspect Hansen when you find any one of the 3. I know Dr. Narasimha has got his own criteria, but I'm just telling you what I teach to my resident. And the absolute criteria is demonstration of acid-fast bacillus with Zeal-Nielsen. You take a slit skin smear and you're able to demonstrate the diagnosis is confirmed. So that could be an absolute criteria when compared to relative criteria. And when talking about redness, there's one more thing that I would like to add when you talk about redness. The child's lesion might be going in for reaction, which Dr. Najeeba will be talking about. Professor Najeeba will be definitely talking about that complication of reactional state. A reactional state is just simply defined as an acute stage in the course of a chronic disease. An acute phase in the course of a chronic disease, where this erythema is very, very common. But again, quickly we'll come to the fact that reactions are not so common in children. Nerve disabilities and deformities are not so common in children. After adolescence, Professor Sudhakar will be telling us more about it. But just as an introduction, after adolescence and in adults only, these children start developing reaction. As I told you, on the face, one has to be careful of the facial nerve. However, what is important is there's always a thought whether the deformity is more on the upper limbs or lower. Is it a claw hand deformity? For instance, we talk about paralysis of the intraocular or wasting of the intraocular muscle. Now, the common action of the intraocular muscle is this: flexion of the metacarpophalangeal joint and extension of the interphalangeal joint. Now, when the intraocular are paralyzed, just the opposite occurs. So what was flexion will become extension, and what was extension will become flexion, and a claw hand comes. And it's important as pediatricians and as dermatologists for one to understand that upper limb deformities are more common than lower limb deformities. Given that the differential diagnoses are varied and many, and the making a diagnosis is important. Now, a skin biopsy is not always possible in children. To do a skin biopsy, they're not going to be very cooperative. Even doing a slit skin smear is very, very difficult in children. So what happens is many of the leprologists, so-called leprologists, when I say leprologists, I'm very sorry to make this statement. I'm not talking about clinical dermatologists and clinical leprologists. The so-called leprologists who are bookkeepers, they keep records. Now, they depend more on the serological tests. Now, there are certain serological markers. One of those tests is FLABS that we call about. Now, these serological tests are not confirmatory for leprosy. They only contribute, and we have to combine it along with other tests so that they complement each other before we make a definitive diagnosis of Hansen's disease or of leprosy. So serological tests are only contributory and not confirmatory. Having said this, I think I will say I'll wait and I request Dr. Jason to introduce Dr. Najeeba Riaz to continue further. Thank you, everybody.
Thank you, Dr. Jacob Thomas, for this opening up the session so wonderfully and telling us about the various aspects of pediatric leprosy that we will be going through over the next half an hour. We'll now have Dr. Actually, it's next to Narasimha Rao to take us through the diagnosis of skin lesions and how do we confirm the diagnosis of the presenting lesions. So, differential diagnosis of leprosy in children will be dealt with by Dr. Narasimha Rao, who is the professor of dermatology and mineralogy and leprosy. He was the national president of the IADVL in 2019, honorary secretary of national IADVL in 2012-13, and chairman scientific committee of ESTICON 2020. 41 publications and 100% more than 100% to his credit. He's been awarded the Shubhpriya Devi Award for Best Original Article in IJDVL 2003 for work on pemphigus, and the IIDVL Precision Award for work on leprosy 2016. So we have another doyen of pediatric dermatology to talk to us on differential diagnosis. Got a lot of orations to his credit, and his areas of interest are leprosy, connected to tropical diseases, pemphigus, and sports. Over to you, Dr. Narasimha Rao. Thank you so much for being with us. Narasimha Rao, please. Yeah.
Very much. So it was pleasure. It is a pleasure to be associated with the IAP of Kerala, and it's privilege to be invited. And I thank the organizers and, of course, the principal, Dr. Jacob Thomas, who has been my good friend and guide, to say, and who has made me a part of this nice seminar. I'm very happy to continue where Dr. Jacob has left it. We are going to talk about differential diagnosis. Yes. Unlike in adults, probably leprosy, especially in its various forms, we find macular forms and scaly forms, sometimes in plaque forms, which can happen in children. It may be slightly confusing because, as rightly pointed out by Professor Jacob Thomas, the lesions will be can be hypopigmented and hypoaesthetic, which is a principal clinical symptom in leprosy. Unfortunately, in children, while we can appreciate the hypopigmentation, it is rather difficult for us to demonstrate the hypoaesthesia because child may not cooperate many times. Number one, the moment you start bringing any object close to him, leave aside a pin, even sometimes even a blunt, even a ballpoint pen, to ask him to say whether this area is numb, he may not respond. So it becomes slightly a problem. But anyway, once someone is carefully and takes the child into confidence, maybe they'll tell it. But in such cases where the diagnosis is sometimes difficult and it can be quite confusing. So one thing we should know is that many times in children, then the lesions are few in number, that is 1 to 3, which usually happens by the time the parents bring the child to the doctor's attention. Most of the time, the lesions are on the exposed areas of the body because many times the lesions of leprosy are inoculated lesions. So these macular lesions, when they look hyperpigmented, the differential diagnosis basically we can consider are early vitiligo or leukoderma of various causes. The second common condition which many of pediatricians and dermatologists come across, Pediatric alba, which can also be slightly hyperpigmented, and also a nevus depigmentosis. Nevus depigmentosis is a nevoid depigmentation sometimes which can happen or which can be seen as a depigmented small macules to large patches on the skin and various areas. Of course, vitiligo leukoderma, one we can say that the vitiligo is completely depigmented compared to hypopigmentation which is seen in leprosy. Vitiligo by definition is a depigmentation of the skin. But Pediatric alba, most of the time the lesions are seen on the face, and as the name suggests, it is pityriasis. Pityriasis means fine scaling. The lesions of Pediatric alba will scale, and If the patient is kept under observation by applying a emollient, generally they resolve within few weeks to months, which can be tested. While nevus depigmentosus, which can happen any part of the body, it can be a small size, a coin size, or a leaf shape to involving a segmental lesions, zoosteriform lesions. But what is the typical characteristic of this nevus depigmentosa are hypopigmented nevoid conditions of the skin are those lesions, the margins are always serrated. When you find a serrated margin, like this serrated margin, usually it cannot be leprosy, because leprosy is a granulomatous disease which spreads peripherally in a uniform pattern. When it spreads in uniform pattern, it cannot be serrated. When the margins are serrated, please have a serious doubt whether it is leprosy. Many a times you can keep the patient observation, it may turn out to be nevus depigmentosus. Lastly, we can have a polymorph light eruption, which can happen in young children and young adults as well. Sometimes this is a basically a inflammation of the skin in reaction to sunlight. Inflammation sometimes can be followed by hypopigmented macules, but these lesions are usually seen symmetrically bilaterally on the exposed areas of the arms and limbs, sometimes on the face, but the patient will be symptomatic here, and naturally these lesions won't be hypopigmented. Can we go to the next slide? We can see the example of how the vitiligo vulgaris here, how it looks on the face. We can easily observe that the lesions are, even vitiligo are, they are not regular, they are irregular in nature. Many times when we see hypopigmented patients of irregular nature, it almost always excludes leprosy. But even though we may not say 100%, but we can always say it is, we can be very, very sure that it may not be leprosy at all. And here you can see on the right side, the picture of Pityriasis alba. You can see multiple lesions of various shapes and sizes. These lesions sometimes can be of a problem in children because, of course, sometimes it may be even for a very experienced leprologist or a dermatologist, even pediatrician, it may be difficult to know whether these patients are cases of early lepromatous leprosy where it can be diffuse infiltration. But if it is Pityriasis alba, they'll be scaly, and if you apply emollient and given some nutritional supplements and vitamins, they may resolve. So when such patients where suspicion is there, it is ideal to always keep these patients under observation. Observation for 3 to 6 months is always safe and time-tested method to see for the resolution of lesions, which does not happen if it is leprosy. Yes. Now you look at macular and scaly lesions. Not just macules, but sometimes they can be white and scaly. Scaly lesions are characteristic of one condition, which is Pityriasis versicolor. This Pityriasis versicolor is common in young adults, post-pubertal, puberty patients and children, but rarely, but sometimes Pityriasis versicolor can involve face in prepubertal children. That can be confusing, but of course, again, as the name goes by, pityriasis means fine scaling. If you use a hand lens and look carefully, you can always find the scaling. And again, these respond to routine antifungal therapy. While it is quite safe to apply antifungals even on the face or any part of the body, while leprosy lesions do not resolve, pityriasis versicolor, you can use of a topical antifungal as a therapeutic agent or a test. Second is Pityriasis rosea. I'm sure many of the pediatricians would have come across this condition, which happens both in young adults as well as sometimes adolescent children, but rather it is very rare and below 10 years. But sometimes it can happen where you find circular medallion-shaped lesions occurring on the trunk, which is usually preceded by a large patch, which is called a herald patch. Here, the scales are arranged as a rim, like fashion at the periphery of the lesion, or the periphery of the medallion-shaped lesion. Third is seborrheic dermatitis. Infantile seborrheic dermatitis sometimes, of course, can start in the first few years of life, but rarely in certain children and infants where the immunity is little compromised, they can extend into the 2 and 3 years of age. And many times, even in the small children, when seborrheic dermatitis clears, it will leave behind certain hypopigmented macules and patches on the skin, which can sometimes can be confused with leprosy. And lastly, tinea incognito, as pointed out by Professor Jaikar, there is a lot of tendency for many of qualified and even unqualified, even qualified dermatologists and practitioners to use steroids for many skin conditions, thinking that many of these dermatoses are steroid responsive, while it is not true. When you apply certain steroids, like the photograph shown by Dr. Professor Jayakar Thomas, we can see the resulting hypopigmentation, which can actually alter the picture and confuse us in the making a diagnosis. In such cases, we should stop all the creams and wait for some time. And of course, if it is a leprosy, the hypopigmentation may be enhanced by the steroid, but hypoesthesia will persist irrespective of use of steroid creams, which will cling, which will give us a diagnosis. Yes, you can see the differential diagnosis for polymorph light eruption. You can see here the face is very oily, and you can see a vague ill-defined patch here, and also one more patch at the chin level. Just at the chin, you can see here at the chin, probably you can see. And also, if it is versicolor, you can see the uniform multiple patches on this right photograph. You can see this oval shaped, and even in this photograph, you can see they are pale and scaly. And of course, the multiple lesions usually occur. But of course, in children, sometimes these lesions, this photograph is of a trunk, but many times in children, sometimes they can occur on the face, which can be of a slight it can become, that's the reason it can become part of differential diagnosis. Yes. Coming to annular lesions, annular by definition means a ring shape. A ring shape means a ring is which is a rim with a central clearing. Sometimes annular lesions can be characteristic feature of leprosy, especially in borderline tubercular leprosy, or sometimes in mid-borderline leprosy, where the rim peripheral area of the leprosy patch can be elevated. But many times these can be confused with a condition, dermatological condition called granuloma annulare, where you can find, by as the name indicates, annular lesions. This is also granuloma, but this is a non-infectious granuloma. And this condition is, there is no associated hypoesthesia, which is characteristic of leprosy. In case of doubt, one can always, skin biopsy will always help in this condition. But one experienced clinician can always differentiate granuloma annulare from leprosy, because granuloma annulare has sensation, cutaneous sensations are absolutely intact. There is no change at all. Coming tinea corporis, as I told you, tinea corporis can have an annularly configuration like this, and sometimes circinate or annular lesions. More so when they are steroid modified. You can see this, they're almost identical repetitive kind of a picture here on the right side, where you can see these lesions. And while compare with them with the left side, even tinea corporis, while here there is no scaling, you can see the scaling is present at the rim, even in tinea corporis, and tinea corporis is an itchy lesion, whereas itching is not a feature of leprosy at all. When any lesion is any circular or annular lesion itchy, it automatically excludes leprosy. Leprosy lesions are numb or hypoesthetic, never never painful or never itchy. Painful rarely if they are inflamed, but itchy never. Lastly, when come to nodular lesions, which can have a multiple nodular lesions, can happen sometimes in a advanced form of leprosy called as lepromatous leprosy or a histoid form of leprosy. Such presentations are rather rare in children, especially young children below 10 years. It is very rare, but we do find such, unfortunately, such kind of a nodular lesions in older children and young adolescent children. But one of the different diagnoses we should consider in such condition is neurofibromatosis, which is, as you know, is a genetically mediated disorder, autosomal dominant type, and of course it can be because of spontaneous mutations as well, where you can find a molluscum fibrosum, where a firm multiple papules and nodules occur, along with the appearance of a KFULA macules, which is characteristic of this condition. Of course, these are symmetrical, and of course, there are no nerves can also be thickened. Neurofibromatosis, I think, if postgraduates are listening to the lecture, please note, this is one condition where peripheral nerves can be thickened, but there is no associated nerve function impairment. That means there is no motor or sensory deficit in the acral areas compared to leprosy. So this is probably the common differential diagnosis. And now coming to the last part of my differential diagnosis. Yes, once you make a differential diagnosis, yes, still we have a suspicion of leprosy. How to confirm it? Dr. Jacob Thomas has so eloquently mentioned how he teaches his students about it. I absolutely concur with him. But only thing is, I can only say that the presence of anesthetic skin lesions, which are hypopigmented, probably is considered as a one diagnostic criteria by some leprosy authorities, especially international WHO and other authorities. While we can always consider hypoesthesia one of the features, but hypoesthesia combined with anesthesia or hypoesthesia combined with hypopigmentation makes it doubly suspicious of leprosy. Number two, demonstration of thickened peripheral nerve or peripheral nerve enlargement, which is a clinical skill which has to be learned by the student or the clinician, which can be easily learned in practice. And lastly, demonstration of ambulatory. Only one of the three features needed to make a clinical diagnosis as of now: anesthetic or hypoesthetic skin lesion or thickened peripheral nerve. Of course, the confirmatory is demonstration of leprosy. Of course, in addition to this, we can always confirm the diagnosis by skin biopsy by looking at histopathological picture. As we all know, as we all understand, that skin biopsy gives the ultimate diagnosis, histopathological diagnosis, ultimate diagnosis to confirm any pathology. I think with this, I think that differential diagnosis, I conclude my part of the talk.
Thank you, Dr. Narasimha Rao. Dr. Jacob, do you want to say something? Do you want to add on something? Dr. Jacob? Can you unmute?
In terms of adding on, from the pediatrician's point of view, because I get to interact with them a lot till recently, even at the Kanchi Kamakoti Child Trust Hospital. Most of the patches, most of the time, the pediatricians are very fond of using anti-helminthics. First thing is they jump at anti-helminthics and give anti-helminthics and say it's because of worms and things like that. I think that should be avoided because without making a diagnosis. Instead, again, I just recall what I usually tell my residents. You get a hypopigmented patch for quick reference. A quick reference, divide them, scaly, non-scaly. If they are scaly, pityriasis versicolor, pityriasis alba, pityriasis rosea, seborrheic dermatitis. If they are not scaly, vitiligo, Hansen's disease, any of the neoid conditions you could think of. So that way, if you keep in mind, it's easier to make a diagnosis, a differential diagnosis. And as Professor Narasimha rightly, my final quote of the week is, of course, skin biopsy, which is not very easily done in children. It's not very easy to do a skin biopsy in children, but still it's important because particularly when we deal with a special form of leprosy known as indeterminate Hansen's. Now, indeterminate Hansen's, as the name suggests, is not determined by anything. It is clinically indeterminate. We may or may not have sensory impairment. So clinically indeterminate. Bacteriologically indeterminate. May or may not find acid fast bacillus. Histologically indeterminate. It might show a macrophage granuloma. It might show a lymphocyte granuloma with giant cells, with them a epithelial cell granuloma. Also, therapeutically, it is indeterminate. We do not know whether to treat it as paucibacillary or multibacillary. And finally, it's immunologically indeterminate because when you do a leprosy test, we usually say a leprosy test is positive when the immunity is high, and it is negative when the immunity is poor. Again, it becomes indeterminate. So these are some points which I would like to, share with the pediatricians. Not that I want to add on to what Dr. P. Narasimha Rao said. I just like to just share with the pediatricians. Thank you, Dr. Thank you, Dr. Narasimha.
Thank you, Professor Narasimha Rao. Now we'll have the diagnosis that's made. A pediatrician like me at a loss, we're not familiar with the management of these cases. We're not aware of the complications that can develop and when it develops. What are the recommendations for management of these complications? So to take us through that, we have Dr. Najima Riaz, who is professor and head of dermatology KMCT Medical College, Calicut. She was a former professor and head of dermatology at Government Medical College, Calicut, and president and secretary of the IADVL Kerala. She was former dean of medicine, Kannur University, and assistant editor of IADVL. Member of the editorial board of IADVL and the section editor of MCQ IADVL, concise textbook of dermatology, and reviewer of Indian Journal of Dermatology, Venereology, and Leprology. A lot of awards. The IDVL Best Teacher Award in 2021, very recently. Professor B.M. Ambani National Oration Award, Kerala Professor B.K.H. Nair Memorial Oration Award 2013, Professor Sardari Lal Oration Award, Dermazone South at Jipma, Puducherry in 2014. He's got many publications, he's authored a book on dermatology digest, and the co-author of 4 books and chapters and contributed textbook in 12 textbooks. And her areas of interest are genodermatosis, drug reactions, and pigmentation disorders. Over to you, Dr. Najima, for your talk on the treatment of childhood leprosy.
Thank you, Dr. Jason, for the nice words. And I would like to thank you and as well as the team IAP for inviting me for this. Well, a diagnosis of leprosy is often associated with significant social stigma. So hence, before starting treatment, it's always important to reassure the patient as well as the parents of these children, which will help to make them compliant with the treatment as well as improve their self-esteem as well as the self-confidence. And always you have to be to take care of the general health and diet of the child. And baseline investigations are always important before starting treatment because uh, some of these anti-leprosy drugs can cause derangement in these values. So check and see whether these are normal, the hemogram, renal function, as well as the liver functions. And always inform the patients and the parents about the possible side effects, even though these are very rare, because suppose the patient can see the yellowish discoloration of sclera or the bluish discoloration of the fingertips, any form of itching. This could be the earliest manifestations of these side effects. So if you do not stop the drug, this can lead to severe complications. So at the onset of these things, they have to stop the drug and report back to the doctor. That should be informed about. So coming to the treatment of leprosy, the multi-drug therapy is the specific or the mainstay of treatment, which was first introduced by WHO in 1982. And for treatment purposes, leprosy is divided into paucibacillary and the multibacillary types. Paucibacillary are the tuberculoid or TT, BT is the borderline tuberculoid, I for indeterminate, and N the neuritic types. These are all smear negative types. Whereas multibacillary are the smear positive types like the lepromatous LLBL as well as the mid borderline. For the paucibacillary types, 2 drugs are given, only 2 drugs, that is dapsone and rifampicin. And that's a dose you can calculate per kg, 2 milligram per kg for dapsone daily. Rifampicin is given monthly in a dose of 10 mg per kg on empty stomach. And these 2 drugs are given for a fixed period of 6 months. That's called the FDT or the fixed duration therapy. And then you just stop the treatment. For multibacillary, in addition to these drugs, you have to add one more drug, that is clofazimine, in a dose of 1 mg per kg daily and 6 milligram per kg monthly. And this should be given for 12 months or 1 year and then stop the treatment. And that's the recommended regime. And this is just to show the rough dosage for the pediatric age group. For paucibacillary, in the age group of 10 to 14, it's about 450 milligram rifampicin and 50 mg dapsone. That's all, roughly the half the dose of adult. And above 15 or above, the dose is the same as the adult dose. You should know that the maximum dose should not exceed this 600 and 100, even if you calculate per kg. And for multibacillary types, same, these 2 drugs are the same dose with clofazimine. For 10 to 14 age, it will be 50 milligram alternate days because clofazimine is available as 50 mg or 100 mg capsules only. So you can't make it half or like that. So instead of daily, you have to give 50 mg alternate days for 10 to 14, and supervised dose is monthly 150 mg. This is roughly half the dose of the adult. And 15 or above, the same as the adult dose. So reactions are rather very rare in children, especially. They better tolerate all these drugs, but rarely you may come across with this some of these side effects. The hemolytic anemia is said to be the most common side effect due to dapsone, especially those with a G6PD deficiency. So if facilities are there, we can always do a G6PD level in such patient before starting dapsone. Then methemoglobinemia is another common side effect characterized by this bluish discoloration. That's why they will be observing if you tell them before starting treatment. And hepatitis can rarely occur. All types of hepatitis have been reported. Other side effects are motor. We'll come to hypersensitivity last. Motor neuropathy, albuminuria, dapsone psychosis, woolly headedness are some other side effects of dapsone. Then rarely you may come across FD, fixed drug eruption, Stevens-Johnson syndrome, and TEN. But the most serious side effect of dapsone is a dapsone syndrome, or DHS, that is drug hypersensitivity syndrome, also known as DRUS, that is drug reaction with eosinophilia and systemic symptoms. This is actually an idiosyncratic reaction. This has to be the onset of the reaction. You have to stop the drug. If you continue dapsone, this will end fatally. So that's the importance of detecting this early. This usually starts within 6 weeks of starting treatment. Start as a facial erythema, edema, or a maculopapular rash, pruritic maculopapular rash, which can progress to exfoliative dermatitis. You can see that unlike SJS and TN, the mucosal involvement is much less here, rather spared, the conjunctival and the lip, and the buccal mucosa. The other features are generalized lymphadenopathy, and the peripheral smear will show eosinophilia as well as atypical lymphocytes. And this will help to diagnose the dapsone syndrome. The treatment is immediately you stop dapsone and start on systemic steroids. So there will be a dramatic response to systemic steroids in such patients, but this has to be continued for about 4 to 6 weeks. A prolonged treatment with steroids is required in dapsone syndrome or all types of drug hypersensitivity. Rifampicin, again, the commonest side effect is the reddish discoloration of urine. Then flu-like syndrome, body aches, malaise, fever, thrombocytopenia, and transient elevation of liver enzymes. Hepatitis is also very rare. And rarely you get renal failure also. Clofazimine is a drug which is without much side effects. A photomelanosis, that's a brownish discoloration of the exposed areas, or sometimes the lesions can be seen. Then acquired ichthyosis, you can see this as second slide. It's just ichthyosis-like lesions. The skin lesions of HD become ichthyotic, as well as there will be diffuse ichthyosis of the extremities. Then abdominal complaints, cramps, diarrhea, melena, and sudden deaths also have been rarely reported. Coming to lepra reactions, as Professor Jacker has already mentioned, these are acute exacerbation during the course of the illness. This can occur with treatment as well as without treatment. It's not actually a complication of treatment, but it usually develops during therapy. And these reactions are rather much less common in children compared to adults. You can see that the chance of reaction is about more than 50% in adult, whereas it's about 3.1 to 33% in children in various studies. These are some of the precipitating factors for lepra reactions, like intercurrent infections, injuries, surgical procedures, psychic or physical stress, immunizations, vaccinations, and following the anti-leprosy treatment. These are some of, suppose the patients develop any reaction to these usual drugs like dapsone, rifampicin, or clofazimine, you can think of the second line drugs, which are the newer drugs like ofloxacin among the fluoroquinolones, clarithromycin, which belong to macrolides, and minocycline of tetracyclines. This can be offered. Reactions, there are mainly two types, the type 1 and the type 2 reaction. The type 1 reaction usually seen in the borderline types only, that is BT, borderline tuberculosis, mid borderline BB, and borderline lepromatous. Because all these borderline types are in the immunologically unstable types. So with the treatment, usually this type of reaction develops with treatment. That's within a few months after starting therapy. Due to the rapid destruction of bacilli, there will be an immunological reaction. That's a type 4 hypersensitivity or the delayed hypersensitivity. Actually, with treatment, there is an improvement. That's the upgrading reaction you get. So characterized by, you can see there will be existing lesions. The next slide, the existing lesions of its leprosy. You have seen the normal lesions shown by Professor Jaker. So the lesion, those lesions become erythematous and edematous, tender, like that, like this. May be associated with severe neuritis with nerve palsy and nerve abscesses. Sometimes new leprosy lesions may even develop. But in spite of these changes, there won't be much constitutional symptoms. That's one characteristic feature of type 1 lepra reaction. This is another case of a borderline tuberculosis with a type 1 reaction. You can see the satellite lesions here. That's a typical of the borderline tuberculosis leprosy. The lesion has become erythematous and edematous. Next. Coming to type 2 reaction, this is seen only in the lepromatous spectrum, only in LL and BL. And this is actually an Arthur's phenomenon or the type 3 hypersensitivity mechanism or the immune complex deposition. So this is seen late in the course of the treatment when most of the bacilli are fragmented or granular. They form antibodies and form immune complexes. And these immune complexes get deposited in various organs. And the characteristic lesion of type 2 reaction is called the erythema nodosum leprosum, which are actually crops of tender erythematous nodules, which develop mainly on the extremities and face, and they subside, then another crop will develop like that. So crops of lesions will develop. But unlike the type 1 reaction, you can differentiate this from type 1 reaction. That is, there is no change in the existing HD lesions. You have seen in type 1 reaction, lesions become erythematous, edematous. But here, the HD lesions will remain as such without any change. But you get the new erythema nodosum leprosum lesions only. And there will be associated severe constitutional symptoms with a high-grade fever with the vestigium in the evening. There are some other features of lepra reaction. So I told you that generalized inflammation is the feature of type 2 lepra reaction. There will be fever, neuritis, myositis, arthritis or arthralgia, rhinitis, epistaxis, acute iridocyclitis, dactylitis, lymphadenitis, epididymoorchitis, glomerulonephritis, etc. There's inflammation of several organs you get. This is another rare type of reaction. For completion's sake, I have included. That is called the type 3 lepra reaction or the Lucio phenomenon. This is seen mainly encountered in Mexicans, seen only in Lucio leprosy. So what's Lucio leprosy is? It's a variant of lepromatous leprosy characterized by diffuse infiltration. There won't be any nodules as in usual lepromatous leprosy. Nodules or plaques are not there, only a diffuse infiltration. And here they develop multiple erythematous patches, become purpuric, necrotic, and heal with scarring. So this is actually a type of vasculitis. It's extremely rare in children. Coming to some of the principles of management, the early initiation of treatment is very important for any type of reaction. But you should remember that it's not an indication for stopping multi-drug therapy. The therapy should be continued, it should not be stopped. Any precipitating factor like intercurrent infection, stress, etc. should be removed. And mental and physical rest is very important. Management of type 1 reactions is mainly management of neuritis. For mild types, only NSAIDs are required, like non-steroidal anti-inflammatory drugs, aspirin, and severe cases may require systemic steroids. Usually, this is the dose 30 to 40 to start with, and gradually taper. May require slightly prolonged treatment. Type 2 reaction. Again, to correct the infections or precipitating factors, analgesics may be required because severe tenderness will be there of ENL lesions. Tranquilizers may be needed. Thalidomide, which is not usually given for children. Chloroquine and high-dose clofazimine are other drugs used for type 2 reaction because clofazimine has an anti-inflammatory effect as well. Then pentoxifylline is also because of the anti-inflammatory effect can be tried. These are some alternative drugs for type 2 reaction. Usually analgesics and thalidomide not in children but in adults. Steroids are given in severe cases. Systemic steroids are required. Thank you.
Thank you, Dr. Nazima, for that very excellent description of the management. Dr. Jacob Thomas, do you have any comments?
Just a few points, which might help the pediatricians. Very nicely put, the treatment of both paucibacillary and multibacillary. We see paucibacillary frequently, more frequently than multibacillary. Rifampicin. Rifampicin is a common drug and very important the use of rifampicin because it is said that one dose of rifampicin kills more than 99% of the bacillus. Just one single dose of rifampicin. So that becomes very important for pediatricians to use rifampicin. Make sure, but unless and until, of course, you have proved that rifampicin is not helpful. Another drug is, of course, dapsone, and as Madam has already pointed out, the dapsone hypersensitivity syndrome, the dapsone syndrome, things like that, then we have to start looking at alternate drugs. And what is the thing that even if it is paucibacillary, we will have to start using clofazimine. We cannot, because there we cannot use a tetracycline in children, like minocycline. Minocycline, we always reserve them for adults. Very correctly brought out. And then, of course, I thought for pediatricians, one more point will be interesting about this erythema nodosum leprosum. We get to see erythema nodosum frequently. Now, what is the point of difference between erythema nodosum and erythema nodosum leprosum? Clinically, both of them might appear the same, because I've seen umpteen number of erythema nodosum in children. Just with streptococcal infection, they come and develop erythema nodosum. The point is, in ENL, that is erythema nodosum leprosum, the lesions tend to ulcerate. In erythema nodosum, they do not ulcerate. So erythema nodosum can ulcerate in two situations. One, when it is erythema nodosum leprosum. Number two, when it is associated with ulcerative colitis in a child. So these two, ulcerative colitis and erythema nodosum leprosum, are known to sometimes, not sometimes, always ulcerate, whereas other forms of erythema nodosum do not. That's very nice. Thank you very much, Dr. Najiba.
Thank you, Dr. Najiba. Thank you, Dr. Jaika. And now we have these children that go on, some of them develop deformities. We would like to know how and when these deformities occur. Are we seeing less and less of these complications? What are the surgical options available for managing these complications? And invite an expert on the subject, Dr. Sudhakar, to enlighten us on this topic. Dr. Sudhakar is Professor and Head of Department of Plastic Surgery and Principal Dean, Andhra Medical College, Visakhapatnam. The former Superintendent, KGH, Visakhapatnam. The Chairman, Board of Studies, Dr. NTR University of Health Sciences. Member, Specialist Board, National Board of Examinations. Former Director, Visakhapatnam Institute of Medical Sciences. former member and IC chairman of AP Medical Council. He has done his MCH and MS general surgery and MC's plastic surgery and DNB in plastic surgery from JIPMER and from Chandigarh. PJ Chandigarh, sorry, PJ Chandigarh. And he's got a lot of awards. He's had the outstanding services from the district collector 8 times, and his awards from the Society of Plastic Surgeons, American Society of Plastic Surgeons, Association of Plastic Surgeons of India, and he's got the Best Teacher Award from Andhra, Honorable Minister, Chief Minister Dr. YSR Reddy in 2007. He's delivered many orations and is a recipient of the Rupa, Shilpi, and Seva Brahma Awards. Over to you, Dr. Sudhakar. I'd request you to now share your slides. I'm stopping sharing, so you can share your slides for this talk. Meanwhile, Dr. Jayaraman, our President, IEP Kerala State Branch, you want to say a few words?
Slide, Good evening, everybody. I'm sorry that I could join late. I was a bit late to reach back from the clinic. I'm very happy that Jason had invited me for this meeting about 1 week back itself, and I was eager to attend this meeting because this is regarding an important public health problem and which is often neglected, I think, from the practicing pediatrician side. And I'm very happy that I could attend this update on leprosy treatment and with authorities on the subject. And I thank IEP Kuchin and Jason especially for inviting me to attend this session. Thank you, Jason.
Thank you.
I wish the best for IEP Kochi and this program. Thank you.
Thank you so much. Thank you so much. We'll be calling you next time also. Over to Dr. Sudhakar.
Yeah. Good evening, everyone. And at the outset, I wish to thank the Dean of Dermatology, Dr. Jacob Thomas, for having invited me to participate in this forum. And also, I thank Dr. G. Sanuni for introducing me. And the reason why I'm here today is to share my experiences with the consequences of leprosy. Now that we are dealing with the leprosy amongst the children, and I'm sure that this program is meant for creating an awareness as to what we are going to do with the leprosy in children. As you're all aware that most of these complications which require surgical correction would not occur in children, but as the child grows to the adolescence and adulthood, we see a lot of these complications and we deal with them. So as we all know, that the reconstructive surgery and leprosy will be usually done in adults, and the predominant clinical manifestations are in skin and peripheral nerves, as has already been alluded to. And the onset of this paralysis in nerves is very insidious. It is a very slow process, and the multi-drug therapy and the effective management of the neuritis as a result of secondary to the reactions is reduce the deformities over a period of time. We don't see these deformities so frequently these days because of these two reasons. And whatever deformities that we see will be managed. And I'm going to go through many of the cases in the next few slides. And it has been estimated that approximately 25% of the patients with leprosy would require reconstruction, about a quarter of them. And as we see that the nerves are the ones which get affected most, and the ulnar nerve is the most common one to get affected. And we have the other peripheral nerves also, like median nerve, the common peroneal nerve, facial nerve, and radial nerve in that order of frequency. But most of the time, we have to understand that it involves more than one nerve. And the common pattern of paralysis is amongst the ulnar nerve, which is the most common, is the high ulnar nerve, that is at the elbow level, and the low median nerve. This is the most frequent combination that we see. By high ulnar nerve paralysis, we mean that it occurs above the olecranon groove. In low ulnar nerve paralysis, it is the paralysis just before the effect of the nerve would be just before it enters the ulnar canal at the pisiform bone, which is one of the carpal bones. And coming to the low ulnar palsy, it is basically below the innervation of the flexor carpi ulnaris and the flexor digitorum profundus to the two bellies of third and the fourth digits. Normally, the affected muscles in the low ulnar palsy they are the 7 interossei, the ulnar 2 lumbricals, the hypothenar muscles, and the adductor pollicis. This leads to what we call the classical claw hand or the claw deformity. In high ulnar palsies, both the flexor carpi ulnaris and the flexor digitorum profundus to the third and the fourth digits also get affected. So this is what we see as a typical deformity wherein there is a hyperextension of the metacarpophalangeal joints and the flexion of the proximal interphalangeal joints and distal interphalangeal joint. And the features that we see normally are the wasting, and we see that there is a failure of abduction of the fingers, failure of adduction of the thumb because the adductor pollicis is involved, and we have certain tests, the lumbrical test or the ferment sign, wherein we try to give a card to the individual, and because the adductor is not functioning, the flexor pollicis the flexor of the thumb takes over the action and causes the flexion at the interphalangeal joint of the thumb. So what do we do for this? So for the ulna, the common procedure, though there are hundreds of procedures that are available for different conditions and different clinical scenarios, the common ones that are performed will be alluded to here. Like the common procedure that is done is at sublimis transfer, wherein we take the flexor digitorum superficialis of the middle finger and try to reroute that and attach it to the lateral bands on the extensor sides so that the MCP joints, metacarpophalangeal joints go into flexion. So these are the different steps of the operation. And here is a small video which I'm going to play to show you the different steps that I have shown the photographs. So we can see that an incision is made in the neutral line over the proximal interphalangeal, the proximal phalanx, and the flexor digitorum superficialis. There are two slips of that. One slip is first identified and cut. And then the second, an incision is made in the middle of the palm, and the cut FDS tendons are retrieved here, and there will be 4 different tails of that will be made, and each tail will be brought towards the extensor side and inserted onto the lateral bands. You can see all the 4 tails. It's important to maintain the tension here so that the function will be appropriate. So this is how the sublimis transfer is done normally. The second most common operation that is performed for a similar lesion is what we call the Juncolis lasso operation. Here, the same flexor digitorum sublimis is used, flexor digitorum superficialis, otherwise known as, and here an incision is made in the palm over the metacarpophalangeal joints, and instead of inserting them into the extensor, the lateral bands, here we are going to insert them into the pulleys, A1 pulleys, or A1 pulleys are nothing but the first annular pulleys around the fibrous flexure sheaths. So here we can see the different stages. An incision is made. These are all the different annular pulleys, can be seen white glistening ones. So once the tendon is harvested, both the slips are retrieved in the middle of the palm, they are rerouted after making them into 4 different tails. You can see them making into 4 different tails, brought here, and it is wound round the A1 pulleys, brought out and sutured here so that the metacarpophalangeal joint flexion is achieved. These are some of the results. You can see in the upper one how the extension of the metacarpophalangeal joints, and here you can see post-operative results. Similarly, another similar individual and an youngster having a similar problem, and now you can see how the hand becomes straight and the hyperextension is avoided. Then comes the median nerve. This is most commonly affected proximal to the wrist joint. The effect would be that the thenar muscles are involved and they get paralyzed. And the common ones being the abductor pollicis brevis, the flexor pollicis brevis, and opponens pollicis, and giving rise to what we call an ape thumb deformity, because here the thumb will be in line with the other fingers, other digits. So there are so many different operations that have been described in order to bring back the thumb, known as the opponens plasty. The most common ones are flexor digitorum superficialis used. There are 2 different techniques, or we can use the extensor indicis proprius also, or we can use the abductor digiti minimi or the palmaris longus. Any of these tendons can be used in order to achieve the opposition of the thumb. So this is one similar surgery which is done, but the more common one being the Bunnell's opponens plasty. So here the flexor digitorum superficialis is used, and it is tunneled through the pisiform. Around the pisiform, pisiform is used as a fulcrum, and it is transferred onto the proximal phalanx of the thumb. So this is how it would be to start with, and once we harvest the tendon, and the tendon is rerouted with the pisiform being the fulcrum, and it is inserted at the base of the thumb in order to achieve a result something like that. Child was having an ape thumb deformity that is in line with the other fingers, and now he can clearly oppose this particular thumb. Radial nerve is rarely involved in leprosy. What we commonly see is a wrist drop here, and the lesions in the mid-arm in the radial groove are the most common ones, resulting in a complete paralysis of the main trunk, and the often associated with the ulnar and the median nerve palsy, when we call it as the triple nerve palsy. So various surgical options are available, but what needs to be understood is that we have to achieve the extension of the wrist, achieve the extension of the thumb, and also extension of the digits. These are the 3 important features. The common tendons that are used, the pronator teres, the flexor carpi radialis, and the palmaris longus. These are the common ones which are used to reconstruct. Coming to the common peroneal nerve, the lower limb, it is usually seen as a fusiform swelling of the nerve before it takes off from the neck of the fibula. We all know that it winds around the neck of the fibula before entering into the leg, and as a consequence, all the muscles of anterior compartment get paralyzed. The common one being the anterior tibial nerve, which gets involved, and often the inverters and everters of the foot will be intact. So the dorsiflexion alone is most of the times affected. So most of the times the extensor hallucis tendon is spared. If that is also involved, perhaps we have to make a reconstruction of that also. So the foot drop is a problem in common peroneal nerve involvement. So the common procedure that is done for a foot drop is a tibialis posterior transfer. So the tibialis posterior is harvested and it is rerouted to attach it to the tibialis anterior and the extensor digitorum in order to get the foot into the dorsiflexion. And like I have told you, the facial nerve also gets involved in some of these individuals, and which can be reconstructed. Leg ophthalmos is a condition which results from the facial nerve paralysis. It can be unilateral or bilateral. The most common procedure that is done is we use a temporalis transfer. That means the temporalis muscle, part of the muscle is taken and it is transferred in order to achieve good eye closure. So either temporalis muscle can be used on its own, or it can be augmented by using a fasciolator. You can see the fasciolator being harvested here, which is hooked to the temporalis muscle here, so that the individual gets a good amount of the eye closure. So this is another very common problem. And if you do not treat them on time, there can be corneal ulceration and loss of vision. That's why this should take priority over the rest of the procedures. Here you can see this gentleman having a unilateral leg ophthalmos, and after getting corrected, this is the eye closure that one can achieve. And here this lady is having the involvement on both sides, leg ophthalmos on both the eyes. And this is the eye closure that one can achieve after the temporalis transfer. So in conclusion, one has to understand that post-leprosy deformities are not uncommon. So a quarter of them are quite a big number. And most of the times, the reconstructive methods will address the functional outcome. That means our aim is always to see that there is a good functional outcome without compromising on the aesthetics. So aesthetics is a byproduct of whatever surgery that we do. And one has to understand that all the different procedures cannot be done at one time, and it is often done in stages. So one has to prioritize most of the times, because an individual can have a claw hand and a leg ophthalmos. An individual may prefer to get the claw hand done because of some social embarrassment, or his preference might be a claw hand correction. But we have to understand that the leg ophthalmos should take priority, because if without that, the eye may get damaged and lead to blindness. Similarly, claw hand and foot drop also. Sometimes individuals would like to have the claw hand corrected first, because that is more obvious. So it is the foot drop which has to take the priority, because without correcting the foot drop, an individual might develop other deformities as well. So it is always important to understand that the attitude and motivation are very key in achieving a success in this. That's the reason why there is a preference for doing all these cases, even if they are present in the adolescent age group. We try to wait for some more time, so that individuals will grow up, they will understand the need for post-operative rehabilitation as well as the post-operative advice. That's the reason why it's very important to wait for some time till the patient fully understands the intricacies of the surgery and the post-operative follow-up that needs to be given, and the post-operative advice that needs to be followed. So these two are very key. So in insensate limbs are very difficult to manage, but one has to understand that they have to take care of their insensate limbs quite well. And that is the reason why, again, we wait for some time till they reach the adulthood. And rehabilitation is equally important as the surgical expertise. So this, I conclude, and I thank the organizers once again for having me here on this forum. Thank you.
Dr. Jacob Thomas, do you want to say something? I would like to thank Dr. Sudhakar for this excellent presentation. What a lot of work you're doing in this area. I don't know if there are people who are doing so much of work, on leprosy. You have done it for so many years, but I don't know, the new generation of assistants are getting the opportunity to do this work, because you may be seeing less and less cases. But I'd request Dr. Jacob Thomas to give a final comment on all the topics that have been discussed.
Congratulations, Professor Sudhakar. I am not at all proficient to in any way comment on what all you have said. In such a short duration, you have covered up so much for us and given us so much information. We as dermatologists, I'm sure my colleagues around here also will agree that we have not seen such a grand presentation. And please wait till I'm going to call you again in one of our sessions of the Dermatology Society. It will be definitely called there, and please oblige us again. There's only one little thing that I want. Very nicely, all of you heard Professor Sudhakar tell the 5 nerves: ulnar, radial, median, facial, and the common peroneal. Why? Why are these 5? As pediatricians, I think all of us should know why these 5 nerves are picked up in common. Number 1 is all of them are so superficial that they can get traumatized easily. Number 2, they are all in close proximity to a joint when being used. When the joints are being used, they are liable to get stretched and damaged. And the number 3 cause is, apart from these 2, all of these 5 nerves pass through either a bony canal or a facial canal or an osseofacial canal. So therefore, as they thicken, they get compressed. So a compression neuropathy is very common in these 5 nerves. That's all I can add. Nothing more to what Professor Sudhakar has so nicely put. I'm very thankful to you, Professor Sudhakar. In just less than a week, you have prepared it for us. Thank you very much.
Fantastic conclusion, Dr. Jayakar. Jayakar, you've done a fantastic job in summing up a lot of points for pediatricians. I think questions and answers, we have a few. One is, why is it common in certain states and not in others? See, you have it in Tamil Nadu, Lakshadweep, you have in Andaman Nicobar, some in Andhra, but all states don't have this. Is it to do with the socioeconomic status, or what is the reason? How are we missing in Kerala, missing these cases?
The socioeconomic status, I think, may not be different from one state to the other in such a big way. It might be that lack of awareness is there. It's not that you're missing it. Once you start looking very frequently, even for the rare syndrome, I'm sure Dr. PNR and Dr. Najiba, when we were talking the previous night, we read about a rare syndrome, and when you go to the OPD, it is there in front of us. So it's only a question of awareness. Eye doesn't see what the mind does not know.
Now, the other do you get it in young children, less than 1 year of age? Is it?
Now, there are reported cases. For instance, there is a chap called Rebecca who has reported nearly 100 cases in less than 1 year of age. But generally, we don't talk about infants getting it. But even the standard Joplin's book says in 2 months of age, they have been able to demonstrate acid-fast bacillus as well as see the disease. And this is where we sometimes think that there could be transplacental transmission of Mycobacterium leprae.
Dr. Sudhakar, there's a question. See, if you do these surgeries, will they recur? I mean, this damage can continue if you have a bad leprosy, it's not responding to treatment. Can these deformities recur after treatment?
Recurrence of deformity is very rare. However, stiffness is very common. The training after the reconstruction is very, very important. So that's the reason why a physio is as important as the surgeon in leprosy reconstructive surgeries. So that's the reason why patient has to understand that they have to do this, and they have to have a good physio in order to make them do all the mobilization. That's very, very important. So if they don't do that, the whole operation goes waste, not in the form of recurrence, but in the form of stiffness. It becomes stiff and they'll not be able to move. So
do you wait for complete therapy, I mean, to take effect before you treat deformities?
can you please
wait for the disease to be totally controlled before you do the therapy or the surgery?
Yeah, so most of the times the active disease will not be there because you are going to wait for quite some time. Now that we are dealing with about the children, even amongst the adults, the popular belief is that we have to do the reconstructive surgeries when the active disease is halted.
Dr. Narasimha Rao, have you seen psychiatric and or psychosocial problems in these children with leprosy as they go into adolescence? They're going to have. Do you consult a psychologist or a psychiatrist in these patients? Is it required?
Yeah, yeah, we do find that they are affected psychologically, and of course, socially. Sometimes they feel what called they have distress and also stigmatized. But yeah, I think the counseling by the treating physician and dermatologist is probably important, and the counseling of parents is important. But frank consultation of a psychiatrist probably is rather becomes rare, at least in our Indian settings. Maybe abroad it must be more common. Maybe here a psychology consultant with a psychologist probably will be appropriate if person is very much distressed. But as fortunately mentioned by some of the speakers, Dr. Najima also mentioned, and even the Dr. Sudhakar also has mentioned that presently the visible deformities have actually come down drastically compared to say about 3 decades back. And fortunately in children, the deformities are much less compared to adults. So much so that actually the World Health Organization has taken as children with deformities as one of the criteria to define the extent of disease in the community. And they found that even in India, the extent of deformity in children is rather low. Yes, but having said all this, any individual, including children, can be affected even by a period having a patch on the face, may not have a deformity. So we can as well use a camouflage or camouflaging agents to cover the patches. And for deformities there, the corrective surgeries can be done. And the counseling is probably needed. And best person to give a counseling is the person closest to him.
Thank you. Dr. Najiba, have you seen dapsone resistance, and how do you recognize that? Can you unmute?
Unmute yourself. Unmute yourself, please.
Unmute, please. Yeah.
In children, of course, no, we're not seen any case of dapsone resistance. Usually they respond to the treatment. I have not seen, in adults, of course, we have seen resistant cases. But we can't say it's due to dapsone alone. Most common is dapsone. But no other investigations we can't do now, like the mouse foot pad test.
Dr. Jacob, is the dapsone resistance less because of the MDT, the multi-drug therapy that is now done?
Yes, yes, very, very low. Dapsone resistance, very, very low. But what we fear most is the dapsone hypersensitivity syndrome, because you can lose the child with dapsone hypersensitivity.
Very good. So we're going on to the quiz, so that if there are PGs, if there are no PGs, we'll discuss the quiz anyway, because it's on the. Shall I share the quiz?
Internet connection is gone in between.
Pardon?
Yeah.
Is it visible?
Yes, visible.
Okay. So the first question is this. All these antibiotics have an anti-lepra effect except vancomycin, penicillin, minocycline, ofloxacin, and pfloxacin. The one PG answering. Okay, we're going to the next question. Leprosy can affect all of the following except nerves, skin, nails, eye, and nasal mucosa. I think there's only one PG who's answering.
Is it Professor?
Yeah. One more question. What statement about leprosy is not true? Leprosy attacks retina, causing blindness. The bacteria thrives in cooler temperatures. The bacteria thrives in the nose, in the earlobes, and in the fingers, which is not true. It's not true regarding leprosy. Animals that could have leprosy is the armadillo. Microbial leprae is an extracellular non-pleomorphic bacterium. The incubation period of Microbacterium leprae can range from 9 months to 20 years. In vitro cultivation is not generally possible. The complex and unique cell wall of Microbial leprae is the reason for extremely slow replication rate.
Listen, sir, I must, sir, they are not putting it in the correct order. They have to put the question number in numerical and the answer as alphabet.
Yeah.
So
Please
all of you are answering the quiz. Please do that because it's going to be very difficult to figure out the correct answer later.
Put the numerical question and then the answer is ABC. Okay. Pediatric leprosy which statement is incorrect. Recent report from the National Leprosy Elimination Program of the new case of leprosy in India, 8.7% are in children. Children are believed to be the most vulnerable group to infection with Mycobacterium leprae due to their immature nascent immunity and exposure to intrafamilial contacts. It's not seen in infants. Common age group is 5 to 14 years. The child proportion among newly detected cases of leprosy is a strong indicator of continued transmission of disease and a significant pool of undiagnosed cases in the community. About the transmission and possible source of infection in children, all are true except the risk is 4 times when there is a neighborhood contact. The risk increases to 9 times when the contact is intrafamilial. Risk rises to 14 times if the contact is multi-bacillary form, especially the Lepromyces leprosy, or if there's an index case is the mother. Transparent transmission of leprosy has not been reported. Lepra reactions in children all are true except lepra reactions are more common in children than in adults. Older children and children with borderline disease are at high risk for reactions. Reactional episodes, both type 1 and 2, occur with or without neuritis, has been observed. Lepra reactions are the main cause of neural damage and deformities. And severe reactions are accompanied by fever, malaise, anorexia, swelling of the face, and extremities. Eighth question is, all are true regarding deformities and disabilities in pediatric leprosy except the presence of neuritis at presentation or later on increases the risk of deformity. Children with thickened nerve trunks are 6.1 times higher risk of developing deformities. Multibacillary disease is high risk for deformity. Deformity in children is more common in the lower extremity. Lepra reaction at the time of presentation increases chance of deformity. Methods of diagnosis, including neotech serology and molecular diagnosis method, all are true except none of the currently available tests like the slit skin smears SSS or the skin biopsy is sensitive in children. New serological markers can be used as confirmatory tests for diagnosis of leprosy. PGLI antibody positivity means that 2.7 times higher odds of developing overt disease predicts development of leprosy among contacts in school children and is not useful in the detection of paucibacillary cases. PGL1 also, the diagnostic potential as a single marker in India may be limited to the cross-reactivity of Leishmania donovani. Microbial leprae specific genetic markers, all these markers are potential to diagnose early leprosy in childhood, and sensitivities are approximately 80% and 30% in multibacillary and paucibacillary cases respectively. All are true about treatment except of leprosy, of course, pediatric leprosy, of course. WHO recommends fixed duration multi-drug treatment, MDT, for 6 months in paucibacillary leprosy, for 12 months in case of multibacillary leprosy. MDT takes time to make patients non-infectious. MDT must not be stopped when leper reaction develops. And children with Dapson hypersensitivity syndrome are usually offered a modified WHO MDT regimen consisting of rifampicin monthly and perfamicin daily at usual doses and the same duration. Okay, thank you. I'll now, while Dr. Pramod will be checking out the winners of this PG quiz, I'll reshare the answers so that our experts can talk about the answers so that the PGs understand more about the disease. I hope the clear. Dr. Jaika or Dr. Najima can do that. Najima do the therapy. All antibiotics have anti-leper effect except. Can you explain that, Dr. Najima? Unmute.
Yeah, I think no, the Professor. Also, yes, I unmuted. I think the answer Professor Jaker had already discussed in detail about penicillin, how because penicillin has no action on Mycobacterium leprae. Penicillins do not pierce the no action on this outer membrane and all. So clarithromycin is a newer drug which belongs to the macrolides. It's a newer drug for leprosy with a bactericidal action. Minocycline also has a bactericidal action which belongs to tetracyclines, a newer drug. Ofloxacin, of course, very much high bactericidal activity, belongs to fluoroquinolones. Pfloxacin also has a bactericidal activity, but it's not recommended because of the severe joint problem due to the drug. All others are now considered as a very effective second-line drugs or newer drugs for leprosy, except penicillin. Sparfloxacin also.
Can you take this also? Leprosy can affect all the following except. Najima, Dr. Najima.
Yeah, leprosy usually affects the cooler parts of the body, especially the superficial nerves. The Schwann cells of the nerves are affected, which are cooler. The skin, the nails, of course, is not a cooler part. It's very hard and unable to be penetrated by M. leprae. Eye is also, of course, a cooler part. The superficial parts of cornea is affected. Nasal mucosa also is the one place which is easily affected by M. leprae, which can remain in this nasal mucosal cells.
This
So
answer for
nails
2
is
is
a
C.
part which is not affected. Yeah, C.
Thank you. Dr. Jaika, can you take from now on? What is the statement about leprosy that is not true?
If I go from downwards, bacteria thrives definitely in the fingers, in the earlobe, in the nose, the cooler temperatures. Retina is not affected. Yeah, it's only the anterior chamber of the eye which gets affected. That is the cornea and the iris. Iridocyclitis in a reactional form, and cornea because of the neural deficiency that affects. As Professor Sudhakar said, when there is lack of thalamus, the cornea can get affected, not the retina. The posterior chamber is not affected.
So is it the exposure keratitis or is it the direct affection of the microblood leprae that causes?
So that's the thing. See, it can be as a result of affection of the nerves, involvement of the nerves, causing lack of thalamus and exposure keratitis. Or it could be due to direct what you call a superficial punctate keratitis, which you can get in reactional states.
Okay, next one, Dr. Jacob.
What is not true regarding leprosy? Armadillo is one thing which was first described, the dasypus novum centers. Yes, I told him, I think during the course of my talk, that it is an intracellular obligatory pleomorphic bacillus. The incubation period is, of course, 9 months to 2 years, and then in vitro cultivation is not generally possible. The complex and unique cell wall of M, which I told about the phenolic glycolipid. So M. leprae is an extracellular, is the wrong thing. It is always intracellular, obligatory, and pleomorphic. But I find that there are 2 A's here.
Yeah, I think
squatters would have found it difficult.
my mistake. Sorry. Okay. My mistake there. Okay, pediatric leprosy, what statement is incorrect? Dr. Narasimha Rao, can you take that? Dr. Narasimha Rao there?
I'm here. I'm looking at the questions. Yes. I think we go to.
Sorry. The question is.
Yes, probably yes. I think you have already highlighted it. Not seen in infants. Yeah, but the point is here. I think we should say this. All the statements are probably correct. It is not seen in infants. It's only reported anecdotal reports. But if you ask a postgraduate during an examination, if he says that leprosy is not seen in infants, I think he is almost right. Yes, but still it is reported. But all rest of the are absolutely correct. This is relatively right. But yes, youngest patient has been reported. Yes.
Now this 8.7% you said is the national figure for pediatric leprosy among the total number of leprosy in India.
Yeah, 8.7. Now it has come down to 7 now.
It's come down to 7? Oh,
yeah,
really?
That's what it is.
So it is coming down.
Yeah.
Yeah. So we're scared, this topic was taken up because we're scared with your missing leprosy. We are, because it's so difficult for when you're seeing so many patients to miss out a hyperpigmented patch.
Yes, that we are still missing leprosy. That is for sure. Of course, these are government figures, and you should know how to believe government figures. So government says 7%. So you may take it with like how we should take all government figures. But in practice, we see leprosy probably twice the number of patients generally government says.
Okay. Good. About transmission, Dr. Narasimha Rao, transmission of and possible source of infection in children, all are true except.
Yes.
We said.
All are true, but probably it is risk is 4 times in transplacental. Yes, that is very right. That is the reason the risk is will come from above down. The 4 times, that is government of India is right now giving single dose rifampicin, what is called SDR, to both the neighborhood contacts as well as to the familial contacts. Now the government of India has launched this project of giving single dose rifampicin to both the neighborhood contacts as well as intrafamilial contacts. There is also a proposal to give PEP plus, that is post-exposure prophylaxis, with 2 drugs, that is rifampicin and clarithromycin, for 3 doses for both these contacts. So it is important that is being given because one can get leprosy even from neighborhood. Intrafamilial contact is higher incidence. Yes, the C is multibacillary forms are more infectious. That's why risk is higher. Naturally, mother is the closest to the child. The incidence is higher. Transmission leprosy has not been reported. Yes, this is probably, right, but it is wrong in the sense that there is a scientific proof that it can be transmitted, but in practice, we can all say that by all means that mother to child transmission in pregnancy, during pregnancy, is almost negligible.
Next, Dr. Jaikar, can you talk about the lepra reactions in children? All are true except? Dr. Thomas?
They're not common in children. They're not common in children when compared to adults. They're more common in adults, as I told you earlier itself. So he says reported to vary from 3.1 to 33.9. That's a very wide range, but however, it's not common in children. The other points that are given are all correct.
And the next one about Sudhakar, can you take this? All are true regarding deformities and disabilities in pediatric leprosy, except the Dr. Sudhakar. Presence of neuritis at the presentation or later increases of deformity. Dr. Sudhakar, are you there?
I think he has left.
Okay, then Dr. Jacob, can you take that?
Yes. I also mentioned when I was talking about it, that deformity in children is more in the upper extremities. We find them a claw hand and wrist drop, more of claw hand that we see, and the deformity is more in the upper extremity, not so much in the lower extremity.
And diagnosis, Dr. Narasimha Rao, can you take that?
I'm just unmuting. Yes, I think, yes, this is new serological markers can be used as a confirmatory test. Yes, they may not be confirmatory tests, they are only supplementary tests. That's the only thing we should say. And right now they can be called as supplementary tests. Confirmation is still by slit skin smear to confirm the presence of AFB. But right now, skin biopsy is very sensitive. PGL is being used. This is widely used in South America, Brazil, and of course in India we are not using much. And this may be limited because of cross-reactive Leishmania donovani and other, even Mycobacterium tuberculosis as well. And of course it is not very sensitive in TB patients. That's one reason we are not using it, like passive basal. That's important. Of course, these markers are used, in big laboratory settings and institutional settings, but still to come forward into the general population and availability at various hospitals in general. So as of now, the serological markers are not much used in India, while they are being used more frequently in Western countries, especially in Brazil and other countries.
What is the yield of the slit skin smears? I believe it's increasing, it's getting better and better. What is the yield? Because initially 20%, 30% it's getting better. Is that true?
Yeah, the point is that slit skin smears can only be positive in a multibacillary leprosy, which is otherwise we can say that's only in borderline lepromatous and lepromatous leprosy. While in tuberculoid and borderline tuberculoid, the skin smears are generally negative, while we see number of patches. So that limits the confirmation to mostly multibacillary type of leprosy. That is probably the limiting factor of slit skin smears. But when they are positive, that means leprosy is confirmed.
The percentage, what is your percentage yield? Dr. Jacob can also come in and tell us, what is your percentage yield of skin biopsy?
In biopsy?
Yeah.
Skin biopsy can be close to 100%, but slit skin smears is very, very low because we rely on skin biopsy in a big way. But I just thought this serological tests or serological markers, the importance of them, that they're only, as Professor Narasimha Rao said, they are only complementary or supplementary. You have to add on something else because the serological marker will become positive when M. leprae enters the skin. When it enters the system, that's all. That's all it will say, that there is M. leprae in the system, not that there is disease. Whereas you do a lepromin test also, then when you find that a lepromin test is negative, which shows that the immunity is poor in that particular individual, and the FLABS test is positive, which means that M. leprae has entered that particular person. So a person who is harboring M. leprae and who is likely to have a poor immunity is a person who is prone to get the disease, and therefore you can start on chemoprophylaxis. That's why it becomes important, of epidemiological importance.
Okay, this is on treatment, drug treatment, Dr. Jaikar, or finish that?
I said this again, point number C, where one single dose of rifampicin can cause more than 90% kill of Mycobacterium leprae. That's why MDT takes time to make patient non-infectious is not correct. It's not correct.
Thank you so much.
Professor Najiba had already said.
Mentioned all that. So can Dr. Pramod announce the winner?
Okay, Dr. Sravani Muddada, who's a plastic surgery PG at Andhra Medical College, Vishak has won the Vishakhapatnam has won the quiz.
Dr. Sudhakar is protege here. Dr. Sudhakar?
Yeah, sir, she's my resident.
Very good. So congratulations, Doctor. Can you show yourself? Who's that? Can you?
Dr. Sravani.
Shravani? Anyway,
Yeah,
congratulations, Shravani.
yeah.
Oh, thank you, Dr. Shravani, for
Good
your
evening, sir.
participation
Thank you,
and all
sir.
the work that you're doing in this field. I wish you all the very best for the future, for all the activities that you're doing in plastic surgery. Congratulations.
Thank you, sir. Thank you.
Congratulations, Dr. Shravani.
Thank you, sir.
It's always the MCH and DMs who usually win the quiz in our potpourri. I now I thank all the Dr. Jacob Thomas especially here. Thank you so much for getting this through, Dr.
Very welcome, very welcome.
Dr.
I have to thank Professor Sudhakar, Professor Najiba Riaz, and Professor Nasimara. Within a week's time, they got, less than a week's time, they got, because you had told me, Dr. Jason, more than a month ago, but somehow there were so many webinars coming, I forgot about it. And then when Dr. Najiba reminded me, I quickly worked on this, and they were very kind to oblige, very kind. Thank you all very much for that.
I invite Dr. Pramod Warrior, our president, to say the vote of thanks, official vote of thanks.
It was an eye-opener for most of the pediatricians here. And I must thank Dr. P. Narasimha Rao, Dr. P.V. Sudhakar, Dr. Najiba Riaz, and finally, Dr. Jaikar Thomas for organizing in such a wonderful manner, and all the participants. And also, thank you, Dr. Jason, for conducting the webinar. Thank you all, and good night.
Good night. Thank you so much. We'll keep in touch.
Good night.
Please do keep in touch. Thank you very much and good night.
So much, everybody.